Hi, for our nursing case, we are doing community-acquired pneumonia and nursing management of. I'm Stephanie Cameron. I'm doing the introduction, case scenario, and nursing management.
I'm Ishara, and I'm going to be doing pathophysiology of community-acquired pneumonia along with
my name is Vijayanti Gunawardena, so I'm doing the pathophysiology and nursing management with Ishara.
Yeah.
Hi, I'm Upma, and I'm doing the medications.
And then, for community-acquired pneumonia, and we're all just going to cover the nursing management as well at the end.
Community-acquired pneumonia, referred to by the acronym CAP, is a highly common and potentially serious disease that is currently ranked fifth leading cause of mortality globally. It is defined as a syndrome in which acute infection develops in the lungs of an individual who has not recently been hospitalized nor had regular contact with the healthcare system. During periods of influenza outbreaks, the common flu virus can act as a principal cause of most CAP cases, causing hospitalization, with secondary bacterial infections also acting as a major contributor. Our group's case study investigating the treatment and management of community-acquired pneumonia. We will be utilising the case scenario of Gregory Jones. Born in 1944, Mr. Jones is a 72-year-old man who is currently partially retired from a long career as a tradesman, and he does casual handiwork in his neighbourhood to supplement his income. Since his wife passed away from cancer 5 years previously, Mr. Jones lives independently and has regular contact with his two adult children. His current health status includes a high BMI, poor diet that comprises of a lot of prepackaged and takeaway foods, participation in social drinking weekly, and a history of heavy smoking of more than 20 cigarettes per day. Current known medical conditions are hypertension and a diagnosis of stable angina in the past 12 months. For this condition, he is presently on the following medications daily: 50 milligrams of metoprolol twice daily, 75 milligrams of ibuprofen morning, and 80 milligrams of abestratin at night. At 9:40 p.m, Gregory Jones presents to the emergency department with complaints of sharp chest pain, shortness of breath, persistent cough, chills, and fatigue. During an initial nursing assessment conducted, it is established that Mr. Jones has a low-grade temperature, slightly elevated respiratory rate of 27, and is currently being treated for stable angina with 50 milligrams of metoprolol. A 12th lead EG is performed with normal results, and staff transfer him to the short-stay ward to monitor his condition overnight. During the night, Mr. Jones's respiratory rate increases significantly to 32 breaths per minute. His low-grade temperature develops into a fever, oximetry reading drops to 90%, and he begins to cough up yellow-coloured sputum. Upon further investigation by medical staff, Mr. Jones informs the nurse that he contracted influenza-like symptoms in the previous week after working in cold conditions, which he took paracetamol for. Oxygen therapy is begun immediately as a chest auscultation is undertaken, chest X-ray is ordered, and blood tests for FBC and WCC are taken. With the results received and assessed, Mr. Jones is clinically diagnosed with community-acquired pneumonia and treatment is begun.
Azithromycin. Its a indication is this drug is used to treat acute bacterial bronchitis caused by influenza. Mild community-acquired pneumonia is caused by influenza as well. The contradictions are this medication is contradicted in individuals with who are allergic to similar drugs in the class macrolides, and do not use this medication if you've ever had jaundice or a liver disease. The side effects that can occur is difficulty breathing, swelling of the face, lips, tongue and throat. In rare cases, this drug may cause a severe skin reaction that can be fatal if it spreads to other parts of the body. Severe stomach pain, diarrhea that is watery or bloody, headache with chest pain or severe dizziness. The safety considerations are used cautiously in individuals with impaired haptic function. Monitor the IV site for pain and inflammation. Monitor skin for any rashes, and this medication may be taken with or without food. Patient teachings: advise the patient to take the drug as prescribed, even if they feel better. Instruct the patient to swallow whole tablets with water. The medication is moxifloxacin hydrochloride. The indications are for this medication is acute bacterial sinusitis caused by pneumonia. Contradictions are a word used in individuals with prolonged QT interval and uncorrected hyperkalemia. The side effects in central nervous system is dizziness, headache. In cardiovascular system, cardiac arrest may occur. In GI, it's abdominal pain and diarrhea. The safety considerations are cautiously in individuals with significant bradycardia or acute myocardial ischemia. Monitor for adverse central nervous system effects, including seizures, dizziness, confusion, hallucinations. Some serious hypersensitive reactions can also occur, including anaphylaxia when receiving this medication. Patient teaching: instruct the patient to take the drug daily at the same time each day without any regard to meals. Advise the patient to finish the entire course of therapy even if the symptoms are relieved. Advise the patient to drink plenty of water. Warn the patient that the drug may cause dizziness, therefore instruct the patient to avoid driving until the central nervous system effects of the drug are known to the patient. Instruct the patient to wear sunscreen and protective clothing when exposed to sunlight. This drug is used to treat angina and hypertension. Contradicted in individuals with hypersensitive to beta blockers. The side effects that may occur are dizziness, tired feeling, confusion, memory problems, nightmares, trouble sleeping, and rashes. Safety considerations are monitor the blood glucose level closely and monitor blood pressure frequently. Patient teaching: check the apical pulse before giving the drug, and advise the patient to take drugs at meals. Keep taking the drug as prescribed. Atovestrine indications: this medication is used to reduce low density lipoprotein and total cholesterol levels. The side effects are headache, asthenia, abdominal pain, constipation, diarrhea, rash, back pain. The safety considerations are with individuals with history of liver disease or heavy alcohol use. Patient teaching: teach the patient about proper dietary management, weight control and exercise. Warn the patient to avoid alcohol. Advise the patient to avoid taking the drug with grapefruit juice.
So Vijayanti and I are going to cover the pathophysiology of community-acquired pneumonia. And first of all, Vijayanti is going to cover the overall respiratory system and how it works, first of all, and then I will talk about how it directly influences Greg's case.
Respiration is an involuntary reflex involving ventilation. Ventilation involves inspiration and expiration, which allows lungs to inflate and fill with oxygen. So that's how it happens. And then the expiration means it's deflate lungs to expel carbon dioxide. The lower respiratory tract consists of trachea, lungs, bronchi, bronchioles, alveoli, pulmonary capillary network, and the pleural membranes.
And that's what we're going to focus on for today.
In homeostasis, there's a balance between oxygen and carbon dioxide levels in the blood. However, if an imbalance occurs, the chemoreceptors located in aorta and aortic arteries detect this and then send messages to increase or decrease respiration rate accordingly. Until homeostasis is restored, that abdominal breathing like hyperventilation or hypoventilation occurs. In this case, Gregory, as a smoker, he's actually vulnerable to chest infections because he has breached his respiratory defense. So Ishara's probably going to draw lower respiratory tract.
Yeah.
And then she's going to explain how that happens.
Alveoli provides surface area for oxygen to diffuse into the pulmonary capillaries. So as you can see here, there's a lot of surface area inside, and the oxygen diffuses into the pulmonary capillaries from inside the alveoli to the outside. So, and then the carbon dioxide does the opposite. So it diffuses out of the pulmonary capillaries from here and into the alveoli, so that it could be exhaled out by the person.
Inflammatory response following the invasion of pathogenic microbes start off with histamine, which vasodilates the pulmonary capillaries and become leaking. As a result of that, plasma is leaked into the alveoli and flooding the alveoli, followed by loss of surfactants.
Now on to the continuation of the inflammation process. The excess fluid in the alveolar solidifies. So the solidification of the alveolar space leads to a decrease in air capacity, which means that the surface area within the alveolar is decreased, which prevents efficient gas exchange, so the oxygen diffusion does not occur. Now on to the clinical manifestations of Gregory. So there's an increase of work of breath, and this is due to the body attempting to increase the uptake of oxygen and decrease the carbon dioxide accumulation. Now onto the possible complications following the development of pneumonia. Take into account Mr. Gregory's history of stable angina, shown there, hypertension, and contributing factors such as a high BMI and an imbalanced diet. The condition or state of plaque formation is not known. Therefore, the level of risk of plaque rupture cannot be determined. However, a myocardial infarction is a possible risk. This is due to the likelihood of cytokines which have been released during the inflammation response, aggravating atherosclerotic plaque. Further complications of pneumonia include pleural effusion. This is where fluid builds up in between the chest wall and the lung pleura. A more life-threatening condition includes respiratory shock. This is where the respiratory system inactivates or shuts down. And if the infection persists and becomes localized or spread to the rest of the body, then a septic shock can occur as well. Nursing management of community-acquired pneumonia specific to Greg's case include clearing airway and improving and maintaining respiratory status, and also monitoring ventilation due to inefficient gas exchange and to prevent hypoxemia. For the risk of hypoxemia, monitoring mental state, seeing if the patient is restless, agitated or confused, as well as heart rate, as tachycardia can be indicative of hypoxemia. Reposition the patient and incline the head and prompting the patient to cough and engage in deep breathing to enhance chest expansion to ease ventilation. Providing oxygen therapy with appropriate equipment such as nasal prongs or a Hudson mask, depending on the oxygen saturation level requirements of the patient, and to maintain 94 to 98% saturation of oxygen. Monitoring respiratory rate and auscultation of the lungs to check for the shallow breathing indicative of difficulty expanding the chest, and tachypnea, as well as sounds such as crackling and bronchial breathing sounds, which is indicative of fluid in the lungs. Encourage the patient to cough while in a seated position, as this increases the effectiveness of the coughing. Using suction to clear airway if cough is unsuccessful. Also, collaborating with a respiratory therapist whose role consists of administration of medication to alleviate congestion and eliminate secretion. In the case of high body temperature, monitoring temperature and reducing fever through measures such as lukewarm sponge baths and removal of bed covers, maintaining room temperature to decrease the effects of high fever such as an increased metabolic demand and oxygen consumption. Now, to expand on preventing infection, Standard 3 of National Safety and Quality Health Service Standards. As the certain bacterium determines the specific manner of infection control, the standard approach taken by a nurse when aiming to contain infection is a risk management approach. Since the main concern is transmission, methods such as aseptic technique, care taken when using and disposing sharps, cleaning the patient's surroundings, and sterilizing reusable medical devices are undertaken. NSQHS for medication safety. An antimicrobial stewardship program is highly appropriate and should be in place. The hospital should be in possession of updated guidelines on antibiotic usage, and antimicrobial usage is reviewed. For the safe administration of medication, abiding by the safe storage system of medicine, and also making use of a system to dispose of expired or unused medicine, using updated information and tools to be thoroughly aware of the medication's indications and contraindicators, as well as side effects before administering it.
Drug administration. Nurses are involved in the administration of medication. Therefore, the nurse must make sure that all the rights are followed in order to prevent any medication errors. The right drug, the right patient, the right dose, the right route, the right time and frequency, the right documentation, and the right to refuse. Management. Appropriate treatment requires diagnosis and an assessment of the severity of pneumonia. Nurses should develop appropriate physical assessment skills and use an appropriate scoring tool to assess the severity of pneumonia. Where the diagnosis is clear and the severity is deemed low, patients should be offered a 5-day course of a single antibiotic. The recommended antibiotic is amoxicillin, or an alternative such as the macrolide can also be used for patients who are allergic to penicillin. If the patient is to be treated at home, they should be given advice about supportive measures such as simple analgesia, rest, and fluids. Pneumonia is a painful condition. The inflammatory response extends to the pleurae, which cover the surface of the lung and line the inside of the thoracic cavity.
Inflammation of the lungs causes pleuritic pain, especially during inspiration. Therefore, adequate pain management needs to be put in place to reduce the endurance of excessive pain so that the patient can be encouraged to continue coughing. Pain, specifically pleuritic pain caused by the inflammation of the lungs, can be alleviated through administration of paracetamol.
One of the most vital yet basic factors in the outcome of illness is the correct management of fluid food intake and the promotion of bed rest. For the case study of Mr. Jones, we will utilize the appropriate management of a patient suffering from pneumonia. It is recommended to be standard practice in the seminal work by Dunn 2005 that a minimum of 2.5 litres is ingested orally every 24 hours, or even administered intravenously if required. This is necessary due to the increased fluid loss triggered by Mr. Jones' heightened respiratory rate and fever. Furthermore, adequate hydration will assist in the expiration of the yellow sputum he has begun coughing up. Fluid outtake should additionally be monitored, as significant decreased output is an indication for deterioration in Mr. Jones' condition.
Urine output of less than 30 mL per hour should be monitored and later reported to medical staff if it was not returned to within normal ranges within 24 hours. In addition to fluids, a nutritionally dense and well-balanced diet should be promoted to the patient to aid in his recovery. If Mr. Jones' ability to consume food is compromised by the symptoms of breathlessness and lack of appetite, food replacement supplements and, in severe cases, even perinatal nutrition may be essential. Lastly, bed rest should be highly recommended and, if necessary, enforced for Mrs. Jones due to the strain his community-acquired pneumonia is already placing on his body.